Alrighty, thank you so much for joining us today. Today we are presenting the webinar Future Ready, Emergency Preparedness in School-Based Telehealth. We will be running today's session until 4 o'clock, or just for 1 hour, depending on your time zone. Some quick reminders before we get into content today. All of you are in listen-only mode, so if you'd like to ask a question throughout our session today, we ask that you use the Q&A icon at the bottom of your screen. If you have a question for one of our speakers, feel free to use their name or be specific in who you'd like to ask the question to. If you are open to either one of them, then feel free to just leave the name out of it. If you would like closed captions, feel free to click that CC button also at the bottom of your screen. And we would love it if you could complete our evaluation poll questions that we'll save for the end of our presentation. Then following our webinar, likely next week, we will be able to share the recording, slides, and any additional resources via email with you. And then they will also be shared and posted on our website. So you can go there and access them anytime. If you'd like to learn a little bit more about SBHA, our initiatives, what we do, and how it gets done, I encourage you to visit our website that you can find at www.sbhforall.org. We've got resources and toolkits, some related to telehealth, and if you have any other things that you're curious about school-based healthcare-wise, we've definitely got resources for you as well. With that, I am happy to introduce myself. I am Harper Byers. I'm a coordinator at SBHA. Unfortunately, my colleague Danielle, who's pictured here on the left, is unable to join us as a host today, but in her place, we have the lovely Teresa Bright. If you want to give a wave, Teresa, and say hi.
Hi, everyone. Thanks, Harper. My name is Teresa Bright. I'm an associate here at the School-Based Health Alliance, filling in for Danielle today.
Yes, thank you so much. All right, and I'm actually going to keep it over to you to introduce our presenters today.
Wonderful. Thank you, Harper. First up, we are joined by Teresa Fletcher. She's a nurse practitioner and program development coordinator at Akron Children's with extensive experience in school-based healthcare. She has been instrumental in expanding access to care through innovative telehealth solutions, helping bridge gaps for students who might otherwise face barriers to services. With over 2 decades of clinical experience, Teresa combines hands-on patient care with strategic program development to create sustainable, high-quality health models. She is passionate about leveraging telehealth to improve health equity, increase access, and support student success both in and out of the classroom. We are also joined today by Sulema Sagado. She's the Chief Executive Officer of Global Partnerships for Telehealth, a nonprofit organization committed to enhancing healthcare improvements through the establishment and ongoing support of telehealth programs nationwide. With 2 decades of experience in telemedicine program development, healthcare policy, state and local government affairs, and public relations, Sulema has spearheaded transformative health initiatives across diverse sectors. In addition to her role at GPT, she serves as the principal investigator for the Southeastern Telehealth Resource Center, where she is the liaison to the U.S. territories of Puerto Rico and the Virgin Islands. In this capacity, Sulema collaborates with state and federal agencies, healthcare systems, public health organizations, educational institutions, and technology companies to design and implement telemedicine solutions that enhance access to care. She also provides technical support and strategic guidance to organizations seeking to expand telehealth services in underserved communities. And I will pass it back over to you, Harper.
Awesome. Thank you so much. We are so proud to have these amazing presenters with us today to share more about their programs and their experience and hopefully give you some ideas and thoughts for telehealth in your own life and in your organizations. So by the end of our session today, you will be able to identify policies and procedures that enable school-based health centers and school partners to effectively meet the health needs of students, and describe coordinated systems that ensure continuity of care and support student well-being in remote learning environments. And with that, I'm going to pass it over to Teresa Fletcher to dive more into Akron Children's.
Hi, thanks for having me today. So I just wanted to say that this is such an exciting opportunity, and my presentation is very localized to the eastern side of Ohio, and it's one health system, and then the next presentation will be a little bit more broad, so you'll kind of get two sides of it. But program development coordinator, just I kind of do everything school-based health, but I also am a provider on the side and see these patients, and I think that helped me relate to the work that we do. Next slide. So just a little bit about Akron Children's. We are an independent nonprofit pediatric healthcare system that has been caring for children since 1890. We have two hospital campuses, one of course based in Akron and the other one in the Boardman area of Ohio, which is on the eastern border close to Pennsylvania. We have 7 regional health centers that hold primary care and subspecialty locations along with labs and radiology and physical therapy, and then more than 50 primary care and specialty locations throughout Eastern Ohio. We are the only healthcare system in our region fully dedicated to pediatric care. And when I talk about the model, we're one of the only healthcare systems that hires school nursing staff along with school-based health centers. Next slide. So when you talk about school-based health or school health services, there's really two silos or two houses underneath school health service. We have school nursing and we have school-based health. So school nursing is you're integrated as the school partner for the daily nursing needs of the students. So those Band-Aids and ice packs, medication management, chronic disease management, such as asthma inhaler administration, hearing and vision screenings, and then some health education and immunization compliance. Akron Children's has 44 school districts with school nursing services in 11 counties across eastern Ohio with a population of over 97,000 students. Our back to class rate is 92% for our school nursing, which is exceptional. The national average is around 83% of kids that go back to class after going to the school nurse. So 92% is exceptional. Something unique to us as well is we have a dedicated nurse-led immunization team that goes to all of those 44 school districts administering childhood immunizations and flu vaccines to the kids in school during the school day. Now, school-based health is really our provider-based services, where a nurse practitioner-led team is providing in-person comprehensive care, including well visits, immunizations, acute illness treatment, chronic disease management, using that whole child framework. So everything that you can get done in a primary care office, you can get done in the school. It's very much like field medicine. You just use the resources that you have and you see the kids where they are. But that's really what school-based health is. We do have 22 school districts with provider-based services across 12 counties. I have 9 medical providers. And that includes some full-time, some part-time, and some PRN. And then we do have 85 telehealth devices across those 22 districts. So some districts have a device in every building. Some have one per school district, just depending on the need of that district and the size of it. But we do daily in-person care at designated schools, and then any school system that we have, school-based health services, has the ability to do a telehealth any day that school is in session. We do have point-of-care labs that we do right there in the school, wraparound services with community healthcare workers, care coordination, a school-based asthma treatment program where the kids are receiving their inhalers in school, their controller meds, and then a youth advisory council. So a group of students that we work with to help improve the school, the health of their school and their community. We collaborate with our Akron Children's pediatrics offices, subspecialties, and other local pediatricians on a regular basis. Next. This is just a depiction of all the districts that we're in with school nursing. It's just fun to have their logos on a page. This is all school nursing. And then the next slide, that one is just the school-based health center schools. And so we're slowly expanding over time to get more and more of our districts. And the ultimate goal is that there's a provider that's assigned to every single school nursing school that we have within Akron Children's. Next slide. So the growth of school nursing and school-based health services across Akron Children's Hospital. In 2005, we launched the school health program, and that was in 5 school districts just in Northeast Ohio. So Akron Public and Warren City Schools were one of our first 2 districts. And then in 2019, we implemented school-based health center services in those with donor funding in those 2 districts, so in Akron Public and in Warren City. There was a lot of grant funding available from ODH and COVID relief funds in 2022, and we were awarded the largest grant the hospital's ever received at $3.9 million, and we expanded services into 13 school districts at that time. And slowly, as school year to school year, we picked up more school districts within our system, and we've been marketing our school-based health center services outside of our school nursing network to just have a broader reach. So we do have 3 school districts that we do not have school nurses in, where it is like a school hired nurse that cares for those kids. Next. So what makes us unique? The thing that really makes us unique is that we have our school nursing contracts. Not many institutions, especially hospitals, have that relationship where they hire the school nurses and the school-based health center employees. And so it's a very integrated model, and it really works for accountability. So the school nurse staff is accountable to provide the school-based health center referrals for anything on our symptom lists. And so that helps feed our school-based health center, which is profit. They're billable services. We also have multiple models of care. There's always the saying, if you've seen one school-based health center, you've seen one school-based health center. Well, out of the 22 districts that we have, each individual district is completely different, and even each school within that district is different. And so we have several models of care, which I'll discuss here in a little bit. And then we use telehealth a lot. So when you talk about Ohio and telehealth usage and the devices that we use, we really have the widest reach and continue to provide services in all of our schools every single day without needing that many providers. Next. So just some telehealth stats. In 2025, the hospital had 84 or over 82,000 telehealth visits, and in school-based health, it was 2,000. It doesn't seem like it's that much, but it really is in the whole scheme of things. Our department in general has provided the most telehealth visits using TytoCare in the institution. Next. This is a look at the devices that we use. It's called TytoCare. It is a small peripheral device that attaches to an iPad via Bluetooth. And then it has our electronic medical record. We use Epic on that to see the kids. And so the school nurse or the telepresenter is the one with the patient or the student. And then she operates that device where I can listen to heart and lungs, look in ears, look in throats, look at skin, and things like that. And you can see that provider picture on the left, see how clear that eardrum is. Often if I forget my otoscope at home, I will pull out that telehealth device because it is a great picture. I really feel confident in my assessment skills using this device in order for me to accurately diagnose the patients that I see across the state. Next. So our pitfalls with telehealth, the first couple of years, it was really a struggle. I'm just going to be really honest. TytoCare was not integrated into our electronic medical record. We had a separate video client that we had to use outside of Epic, and it needed different network settings. And so it was very challenging. Over the course of the last 2.5 years, they've integrated it into Epic and using the TytoCare video client throughout Epic, and it's been super great. It's been amazing. There's been a lot less issues, but you have to rely on the school's Wi-Fi network in order to use your devices. It has to have particular network settings, and it has to allow outside devices to be attached to it. And so that's what we see as one of our biggest barriers working with the school Wi-Fi is sometimes the firewalls that they have set up don't allow outside devices to be attached to their network. But we do have kind of an instruction guide and framework for school districts to use to help allow us to use our devices on their network. EMR access has been a challenge as well. So our school nursing partners, our school nursing staff document in the school medical record, the school nursing record, which is within the school. It's outside of Epic. And so we really had to do a lot of training and get a lot of Epic IT access for them to be able to access Epic through the iPad and run those telehealth visits. I did talk about the video client issues between the previous company and now using the Epic video client with the Title Care. That's much better. Staff motivation to be telepresenters has been challenging. Of course, when we first started this program in 2019, people didn't want to be a telepresenter because it wasn't part of their job. It wasn't part of their normal. It was a change in practice. And so there were some people that just didn't want to do it because it wasn't part of their job before. Over time, we've integrated it into the training. And so it's part of their job from day one. They receive yearly training on what to do with it, and it's become less of a barrier. There's still motivational issues. So in some clinics, they say they're too busy or they just don't have the knowledge or the skills to run them, but we are working through that. And then there's also, when we have those telehealth devices, they accompany with point of care lab kits. And so once you collect that lab, you have to get it to the lab somehow. And so courier costs can be expensive. And so can mileage paying someone to transport the specimen themselves. And so just making sure that the specimen's labeled properly, that it's stored properly, that it's picked up and transported properly has created some issues. Next. Successes, we employ our own school nurses, and that is a large success. And we have seen that we now respect that a lot more than we used to, because now we have a couple of districts without our nurses, and we see the barriers that it proposes in those districts specifically. So that is a big win for us, that we employ the school nurses and make it part of their accountability. We do very extensive training for back to school now related to point of care testing and training and telehealth access and using the equipment and referral process. So once we formulated those plans and got them rolling out each year, it continues to get better. And then we have much improved access to care because the student doesn't need to travel. With some school-based health centers, not Akron Children's, the student might have to travel to the building that has the actual school-based health center. So, for example, the hub, so where the provider is, has spoke schools, so the feeder schools from the elementary into that high school. And so in some instances, the student gets transported from the elementary school to the high school where the hub location is. And so that does help not having to transport that student, and we can see them right where they're at and get them back to class a little bit sooner. Next. Okay, that's it. That's the end of my slides.
Awesome. Thank you so much, Teresa. We did have a question for you. I'm going to go ahead and save it for the end, and I'm going to just plug everyone else if you'd like to ask Teresa a question about specific clinic considerations or just anything from her experience. Now's the time. We will also have time after Saleema's presentation to do a co-Q&A. And with that, Saleema, take it away.
Perfect. Thank you so much. You can transition to the next slide. So I'm delighted to present right after Teresa. I think it's so fascinating to kind of hear all the different telehealth case studies around school-based telehealth and what that looks like. And she is right with the whole, there is not one size fits all. And I think what they're doing in Akron is amazing. And it really is a coordinated care system to show kind of that comprehensive care. And it's so nice that when you're able to walk into one location, it's the same across the flow. So for me, I'm going to kind of give a different model and kind of just give a different example and talk to you a little bit about kind of just our organization overview, why we chose school-based telehealth, and how as a company we implement school-based telehealth, some of the services that we provide across the region and across the globe and nation, some platforms and peripheral conversations a little bit similar to what Teresa did, talk to you a little bit about the process flow of what our school-based telemedicine clinics look like, some benefits and challenges, discuss very briefly funding, and then of course always there's a call to action. So next slide. So a little bit about us. We are the Global Partnership for Telehealth. We are based in South Georgia. So we are a rural non-for-profit organization who is really built on the process and overall concept of increasing access to care. So for us, it is really more about empowering communities and looking at telehealth as added value, not a replacement of a medical home, not an extension of a medical home, but really looking at where we can add value and expand scope of services for students, patients across the globe and the communities in which we serve. We really like to focus more on identifying areas of healthcare needs, developing like a digital footprint or a telehealth solution for that organization and or system or educational resource to help address specific needs. So again, since we are not a physician's office, a private practice, we are a telehealth company, but our focus is really on looking at local resources, regional resources, and then state resources to implement telemedicine. We really like to also partner within organizations across the community and across the state to really leverage and expand access to care. Next slide. As a company, just like any other tech companies, we also offer and sell hardware, software, and equipment. So that is really what we do on a day-to-day basis. But most of our work is around implementation of programs and starting up programs. We like to say we're very different in the sense of we just don't sell product. We ask you what product you need or what service you're trying to meet, and then we give you good, better, best options. Next slide. Another thing I'd like to add, out of our organization, we are also part of the Southeastern Telehealth Resource Center called CTREC, which is one of 14 telehealth resource centers. There's 12 regionally and then 2 nationally that are funded by the Federal Office for the Advancement of Telehealth through a grant provided by the HRSA office. And our goal for that is really intended to expand access to care by leveraging telehealth. Our mission is to really serve as a focal point to advance telehealth utilization and support any organization that's looking at implementing and leveraging telehealth technology. As a TRC and being a telehealth resource center, everyone always says nothing in life is free. In this situation, our services within our region and across the nation, all the resource centers provide free technical assistance, again, funded by HRSA. So that is really our goal. So when you see this map, while I am in the Southeast region, which I cover Florida, Georgia, Alabama, South Carolina, Puerto Rico, and the U.S. Virgin Islands, there is also other TRCs within your region that are very similar to myself and my team who could provide that technical assistance. So I encourage you as you're looking at implementing school-based telemedicine initiatives, whether it's telehealth only, a hub and spoke model, really lean on your telehealth resource centers and ask them for support. They're able to tell you who the players are in the community, who's currently leveraging telehealth, maybe what physicians are already in your network or available to you. Again, free resource. So please leverage that. Next slide. As you probably know, since you were on this call today, healthcare access is a challenge. So we know that there are challenges. And while today I'm really going to focus more on our Georgia services, just to kind of give a snapshot since that's our home base. We are based out of South Georgia in Waycross. In our state, it was really interesting to find out that 141 of the 159 counties in the state of Georgia are designated as medically underserved. We know families travel anywhere from 2 to 4 hours just for specialty care. We have families that'll tell us that they live in South Georgia and their students are in Valdosta and they have to drive all the way to Atlanta, which is about 4.5 hours without traffic to get to our children's hospital to see those specialists, whether it's pulmonology or endocrinology. Some of those appointments we know are monthly, they might be quarterly, or they might be every other month. So we know that there's significant healthcare gaps that persist across our rural and underserved communities in our states and your states as well. We also know that there's ongoing workforce shortages that continue to limit the timely access to those pediatric and behavioral health specialists in our state. And we know that health-related issues always remain a major contributor, like chronic student absenteeism and those reduced academic engagement. So for us, we're always looking at ways to add value. According to Georgia Voices, who is an organization in our state who actually does a lot of research for students and education, they identified that more than 170,000 Georgia students miss more than 6 days of school annually, obviously due to unmet health needs. So for us, leveraging and looking at how, as a company, we could help add value and support telemedicine initiatives across the state, I think was a no-brainer to us. We also heard from several families that told us, and a couple data reports that were issued at the state level, was that about 84,000 children in the state of Georgia live in households without reliable transportation and limited access, obviously, to those medical appointments and follow-ups. So we knew that students obviously spend a lot of time in school, and if we could add value to these schools and help support them, that maybe telemedicine would be a great option. We knew it wasn't going to be easy, but we also knew that it wasn't going to be a one-size-fits-all, and we'll talk a little bit more about that. Next slide. So for us, our models, we have two models. So we fully support and love the school-based health center model. That hub and spoke model, we think it is fantastic. Our schools here, Emory, has a huge hub and spoke telemedicine program. They work with our school systems across the state to truly implement and expand school-based health centers. And then now they've started adding an expansion to say we really encourage you to look at telehealth as an added value concept. So the way we like to see it is that is most likely the hub and spoke is more of a closed network that connects maybe a central specialized medical facility to multiple school sites using the telehealth technology. So sometimes partnerships will be with the health system, similar to what you heard it with Akron, or maybe one of our federally qualified health centers in the local community, or one of our community health centers. And then what they do is not only do they have their closed network, but then they add telemedicine for any additional services or to connect site to site. The second model that we see a lot also in Georgia and probably across the nation is just a school-based telehealth program. So it's not an actual center, but it's just a program. And what that means, it's more of just an open network where some of our schools can partner and connect to any provider as needed, and they just leverage telemedicine. So sometimes we'll see these with partnerships with local pediatrician offices, maybe different specialists across the state, and then even some state health programs. So they're not having a full comprehensive program where they have full-time nurses provided by the facility or the healthcare facility, but they're leveraging their existing school nurses or clerks or staff at the schools to be those presenters in the school system, sometimes even front desk staff, and then they're connecting back for specialty care services. And we'll give more examples of those in just a few minutes. So next slide. I think it's really interesting to kind of see what these virtual school-based telehealth services are because it's a sense that it's very local, or some of these services are also district focused. So what specialty services do their students really need? And then where do they currently go? And then they look to see how telehealth will help make it easier for them. So whether it's behavioral health services or dermatology, those care coordinated plans, other specialty services. So we work really closely with our public health departments to refer a lot of our students who are really leaving and having to drive those 2 to 4 hours for those appointments to see if they can leverage school-based telehealth for those specialty appointments. So they would get a hall pass, obviously, and then go to the clinic office or to the designated telehealth suite, and then be connected back for those specialty appointments. We'll walk you through one of those consultations in a little bit and kind of show you what that looks like. But I think it's really interesting that these are really more just focused on those specialty services. They also tend to be scheduled in advance. So they're not real-time consultations. There are cases where some of our school-based telehealth programs allow for just-in-time, depending on who the provider is. But again, they tend to have a schedule mapped out where they work with a telehealth coordinator at the school or the nurse to say, hey, we have this number of slots available this day or this day, or, Johnny, Susie, and Betty need to be seen. Here's where I can squeeze them in. Let's make sure they get seen on those days while they're at school. So again, these aren't just in time, on the spot, kid gets sick, comes into the clinic office for telehealth. Not in all of our schools. In some of our schools, yes, but not in all of them. Next slide. We'll actually go back one slide. I think it's also important to kind of just highlight an example that I think is really cool to see is it could vary from type of school to type of school. So in Ware County School, which is in South Georgia, it's one of our largest school systems. They're using it for behavioral health consults. So they're 12 campuses school system. They average anywhere from 1 to 5 consults a day, which could be really small in some situations, but in others, that one consultation for the day is obviously, we know the return on investment for some of those patients and some of those students. So what they're doing is while they have 12 campuses, they might have a floating nurse or a floating telehealth coordinator who goes to different schools and different campuses on set days. They might have a coordinator that looks at the scheduling system and maps out who's available and what students need to be seen as priority students. But then they commute from county to, well, not from county, from school to school, and they connect those students. So that's why their numbers vary depending on the school and the age group. We also have another program, like for example, which is our Harris County school system. What they decided to do is they decided to partner with one of our academic institutions, our Mercer Medicine School of Medicine. They also have residents there. They're a 7-school campus, Harris County Schools, which is a little bit smaller, but they do have a nurse practitioner who is kind of their point of contact, who connects back to those specialty providers. They have also gotten really innovative and have partnered with their CMOs. So CareSource is one of our biggest CMOs in the state of Georgia, and CareSource is also partnered into the school-based health initiative to help expand access and to make sure that their providers were available to serve the needs of this very targeted community, which I think is one of those innovative ideas that we'll talk about later, which I think is a really cool success. So again, telemedicine services will vary site to site, but it's really localized based on those community needs. I think it's also really important to highlight our partnership with public health and how we are also working with them in the Children's Hospital, Children's for any of those specialty consults, like I mentioned, of like endocrinology or pulmonology. And really, for us, it's really important to realize that while an average could be maybe 5 to 12 visits per day at some of these standard clinics in a traditional school-based health model, or even more, depending on the size, for us, our school nurses aren't using this as just like a end all be all, like immediately come in, patient comes in and there's a telehealth option. They tend to weed out some of those students who really don't need to see a provider because they're also not providing a lot of like immunizations, et cetera, which drives that business and that revenue. They are doing some testing. So whether it's like strep and flu and rapid testing, many of the schools who have telemedicine have those CLIO waivers, but we know funding for them is really limited because they're not fully associated with the health system. So they have to be mindful that some of those boxes of kits, a box of 20 could cost $30. So sustainability plans is really a big deal for them, and we really have to limit how much they can do, but they're very passionate. So next slide. So for us, within our programs, we really pitch the Pathways of Telesensi platforms. There are two web-based platforms. They're not app-based. They're also very low cost. A lot of our schools are telling us that when they have to sustain these programs on their own and they don't have big hospital systems to support them, they need to look for something that's low cost, easy to use, user-friendly, and something that families can connect to from work or from home. So we leverage the Pathways telemedicine platform, which is our web-based platform, which allows our patients, our students, and our teachers, and our faculty, and our family members to connect virtually. Again, no app needed, nothing to download. They literally either get a text message or an email of their appointment, and they're able to click on that link and connect. We also have a telesensi software for teleauscultation, which allows the remote healthcare workers, similar to what Teresa mentioned, to hear those live diagnostics using the digital stethoscope during a telehealth visit. Again, one of the lower cost solutions, easy to use. I think it maybe costs them $20 a month per license, which is very cheap compared to some of the memberships and other platforms that some organizations have to use. We also have various telemedicine peripherals that I'll show you probably on the next slide, but I think it was important for our school nurses. They told us that they wanted something easy, lightweight, but also hardy, that if it fell or it got in the way of different things, that they were able to use. So not only do we have the digital stethoscopes, but we have an otoscope, exam cameras, and then we have other tools for like vital sign monitoring that allows them to connect back to those providers. Next slide. So this kind of gives you a little bit of an idea of what that hardware and software looks like. So to the left, you can see our Pathways, which is our web-based telehealth platform. And then to the right, with one additional click, you're able to connect to our Telesensi, which is a standalone, just web-based platform as well that allows us to hear heart and lungs. As the nurse, you're able to kind of manipulate and move the stethoscope around, and that physician can guide you and tell you exactly where they want you to place the stethoscope so they're able to hear. And then you can also record those lung sounds if you need to, and they're able to upload them as needed. We also have clinical solutions. So at all of our schools, they vary. So depending not only on their budget, but their resources and where they are located, we know that some schools don't have the space to dedicate a whole telehealth suite. Sometimes they're literally working out of a closet that's used sometimes as a backup as a telepresenting site with just a laptop and a computer. Others have like a small, thin rolling cart because they're sharing the space with another's and they just have like a private telehealth area. But others can afford a full industrial telehealth clinical cart that has all the peripherals as well. We also have mobile units, which you can see there, which is kind of like the backpack. So some of those school telehealth presenters who have to fluctuate from school to school, they're able to take the solutions with them. All of this equipment ranges anywhere from $5,000 to about $22,000 is our highest telemedicine bundle package, which I think is fascinating, but again, does the job. And we'll talk a little bit more about funding. Next slide. So for us, when really looking at like the process flow, this kind of just gives you an example. For us, quality of images is the most important. So when implementing a telemedicine program, we know that our physicians and our providers want the quality to be equal then or better than an in-person visit. And these are some pictures that we've actually taken of some of our students. So what you can see is inside the mouth. You can see inside, you can see a tooth where a kid came in with a chipped tooth. That's actually an adult tooth. And then you can see a skin area of concern. And then one day we had a kid come in tugging on their ear. And of course, we found a South Georgia gnat in their ear. So we've seen anything from like Legos in their ears and jelly beans and M&Ms and all the stuff I'm sure you guys as school nurses and or school community members have seen. But for us, quality is of the utmost importance. When looking at a patient flow, it's very similar. The patient or the student presents at the clinic or in the telehealth presenting room, and they're reviewed by that presenter, which is normally either a school nurse or just a clinical staff worker at the school, and they're presented back to the distance site, which could either be public health, that specialty provider, or a community health center via the telehealth web-based platform. That remote clinician will speak with the patient and see them in real time, review any images with the patient, have the presenter show any additional images that needed, all via web-based in real time. And then the patient or the student and the team will develop that treatment plan, any follow-up appointments or anything else as needed. Now you're able to add an additional member to the call, obviously, if a parent needs to be a part of the consultation or an additional specialty provider as needed, and then that flow continues back and forth. One thing that I do say I find interesting is that in many of our school-based telehealth programs, they obviously do not have their own electronic health record. So in our presenting sites, most of the time, our presenting sites are just documenting who they saw and the date and time and for what service. And our providers at the distance sites are the one uploading everything into the electronic health record themselves during the consultation, because many of our schools obviously don't have EHRs, and since they're not connected to a hospital system, they're not connected back on Epic. Which is another reason why many of them choose our web-based platform, because it is just the platform alone and not the integration, because depending on who they're connecting with specialty providers, they would need multiple EHRs, which they obviously cannot afford. Next slide. So for us, we always look at what's the return on investment, as many of you guys know, and I feel like we all know that increased access and the reduction in absenteeism and improved health outcomes are pretty obvious in the decreased ER visits. But for us, like programs across Georgia, such like Harris County schools, really constantly show that reduced absenteeism and improved access to care, not only for their students, but sometimes faculty and teachers are also able to leverage the telehealth and telemedicine clinics. So we think that's fascinating. We also know that students can be seen quickly for some of those common conditions and preventing them having those missed days and escalations of illness. We've heard stories from some of our schools that'll say, hey, our kid went home sick, but I can't get off work. I can't take them to an appointment, or an appointment's not available. So it could be 2 or 3 days that they're still missing from school before they are seen. What some parents would do is take them to the ER, and we don't want them to do that. So leveraging telehealth, we know that the value of being able to use that technology and getting them seen quicker is much better for us. I think we also, for us, it's really important because we have been talking about like emergency preparedness and disaster utilization. And we know that telehealth not only reduces the emergency room utilization, but for us, our families know that they have options and other contingency plans that they may need. So knowing that they can leverage technology, just like we learned with COVID, at just in time and having to pivot, knowing that we have set up that success model and have implemented it and explained to our families what telehealth and what telemedicine looks like, they know that they could leverage those digital tools as well during emergencies. So knowing that our providers know how to connect back with our students, and knowing that our students, our parents, and our school nurses know how to work together to make sure that students are still receiving the care that they need outside of traditional hours, whether it's snowstorm, hurricanes, tornadoes, etc., that really doesn't slow down their care. So we're really appreciative of that. And I think it's really important to also look at telehealth not only as a routine, but also maybe leverage it for that disaster preparedness. Because once you mention the key term disaster preparedness, it opens up a lot of funding opportunities that we might not have thought about working in academics or in any of the school systems. And we could talk about that a little bit more in just a few slides. Next slide. So for us, challenges are very similar to what was mentioned by Teresa. So buy-in is really probably one of the hardest things for us. For us, since we don't pay and fund these school nurses and staff, really helping them champion and learn the value of leveraging telehealth and telemedicine, is really hard for us. Making sure that they're comfortable using technology, that they want to use technology, looking for ways to incentivize our school programs around telehealth and telemedicine. Our schools have gotten really creative, those that support telehealth and telemedicine, and they even sometimes offer stipends to our telehealth nurses for consultations. So they might say, for 150 visits, you get $3,000 bonus. For 100 visits, or for 30 visits, or even if you do 50 visits a year or 100 visits a year, you can get a $2,000 stipend. So again, really, we understand that school nurses are tapped. We understand that they are overworked already. There's so much going on in the school system. Adding an additional service or duty to them is really difficult to pitch. So for us, getting really engaged and looking for options to buy in and to tap in, we love to also highlight and go around our schools and champion for them. I mean, some of my staff have gone in like cheerleading suits and pom-poms and brought in coffee and donuts and really thanked them for their work and given them awards for top consultations of the month or most school that's done the most telehealth consultations of the year. So really supporting that buy-in and that innovation is huge for us. Also, technology and broadband, same thing. Like we know that we are only as good as our internet, and sometimes our internet fails us. We know in rural underserved communities, sometimes the internet is not that strong, regardless of what kind of funding is available. If a train comes through in certain areas, we know that sometimes it drops signal. And if that quality is not there, it makes it a little bit more difficult to be able to have those consultations. Also, firewalls, working with the IT teams at the schools and in the districts to make sure we're opening any firewalls for those web-based platforms and those solutions to work sometimes takes a little bit of time to get implemented. Same for staffing and awareness and just training. Really, the biggest one I think for us is really building that trust and helping our school systems keep those workflows very simple. But of course, funding is typically the hardest challenge if you are not supported by a hospital system. Implementing a school-based telehealth program is really difficult. So next slide. I think for us, we like to say, well, how else do you fund it? And for us, it's been a let's get creative. Like we are here to help you, and we know various organizations that help leverage technology and really looking at telehealth as the standard model of care. So we like to encourage looking at different federal funding and grant opportunities that support telehealth infrastructures and services. We mentioned emergency preparedness and disaster response. You can look at HRSA for implementation startup funds. The FCC has tons of telehealth implementation funding available. Also, there's annual USDA grants that are called RUSDLT grants that help support initial infrastructure and upfront cost. Where you're really going to struggle to find the most funding to support your equipment purchases is not so much actually in the equipment purchase as the sustainability, the nursing, the staffing time. But the equipment, while it may be a little more expensive, there are tons of grant and funding sources and resources that you can leverage to implement and to start these programs in your school system. Whether it's also looking at public health as an asset and looking at your programs that focus on women, infants, and children. So your WIC programs, your emergency preparedness programs, your chronic disease programs are always looking at local community grassroots where you're able to show that return on investment. So maybe tap into some of those state agencies, Department of Community Health in Georgia specifically, and Behavioral Health and Disability, DBHCD, was a huge partner of us and fully supportive of telehealth and telemedicine expansion, specifically for behavioral health and working with our community service boards. And they offered a lot of grants and opportunities for initial equipment and startup funds. So really, sky's the limit when it comes to looking at telehealth options for equipment. It's really more getting creative on some of those sustainability initiatives to be able to fund your school nurses and the staff to be able to manage the day-to-day. Next slide. So for me, I always have a call to action. So I think if this is something that you're interested in, I know there's strength in numbers. I think from a school perspective, if you're joining and you're a school board member, an administrator, I think you should really just look at telehealth and telemedicine and learn more. See what's currently available. If there's any neighboring districts that are currently doing something, if there's any states you want to learn from, just be open-minded to learning more about telehealth and telemedicine and how it can increase access to care within your communities. I think for teachers and counselors and social workers and school staff, like again, we hear you, we understand how overwhelmed you are and how much you have on your plate, but you guys are the voices of the students. They hear you, they know from you, you learn from them, you know what their greatest needs are. So if telehealth can add value and really help support some of their healthcare needs, please help advocate for telehealth and telemedicine. Same for school clinics and nursing staff and our community health providers. You see these students day in, day out. You see their families. You understand their struggles. You hear from them when they come into your clinic. They complain to you all the time about how hard it is. It could be for them to get an appointment. So please consider telehealth as part of your standard model of care. And then for our parents, we always say parents and caregivers advocate and champion for what you want. You know what your families need, you know what you're struggling to have access to. So if you don't ask, you never know what you can get. So we always encourage our schools to also and our parents to ask their school systems about telehealth and telemedicine and to ask their physicians even to say, hey, do you guys currently offer telehealth and telemedicine as, an extension of your clinical program? So that is pretty much it. Next slide. I know that was a lot, but we always realize that there are plenty of people who haven't done this work, and we're always here to answer any questions and to be supportive, and to help any way we can. So think big. It's okay to start small, focus on one area, and then grow your programs from there, and keep your technology as simple as you can. So I'll pause there for questions. Harper, turning it back to you.
Awesome. Thank you so much. I love to give a huge thank you to both of you. I feel also like my brain is full of new knowledge and kind of digesting a lot of that. So we're going to transition with that to hopefully help folks answer their questions and get all the information they need. So I invite our audience members here to use that Q&A function. We've been receiving questions throughout content today, so I think I'll just start at the top and kind of direct them as I see fit. I'm gonna go ahead and stop sharing also so people can see you and it's more fun. So this question, I believe is specifically for Teresa, but Salima, obviously you're welcome to answer it as well. The question is, what specific POCT do you provide in schools? And then also for those who don't know, would love if you could just define POCT.
Yeah, POCT is point of care testing. So it's the in-demand right now answers of labs. And so we do have strep throat tests, we have pregnancy tests, and we have urine dips. We have the ability to collect other samples and send them via courier.
And for us, very similar. So with our clear waivers, they're able to do strep, flu, COVID, and some of those basic rapid testing as well in our clinics.
Awesome. Thank you both. Another question for Teresa here about your contract with Akron Children's for the school nurses and about the use of Medicaid administrative claiming for the work that nurses do.
Yeah, so Medicaid for school nursing is separate from school-based health, and so our school nurses do the Medicaid billing in the schools, and then if they get referred to school-based health, they cannot refer to Medicaid for the school. So you can't bill the same thing twice, basically. But there are kind of procedures based off of what the school wants us to do for Medicaid billing. But many of the times we just do the screening, so hearing and vision screening, and then medication administration that we bill to Medicaid, just starting at that ground level and then seeing how that goes. But as far as the provider-based services, we bill insurances as usual.
Thank you.
And for us, some of our schools work with third-party vendors for billing specifically, and then their presenting sites know that they're also able to bill that presenting fee, so they're able to work together with a third-party billing service to make sure that they're able to receive those claims as both the presenter, but also that provider at the distance site.
Awesome. Alrighty, and then this is open to both of you. A question about how consents are collected in models that are mainly telehealth, or just in general, if you have thoughts about collecting consents through telehealth.
So we have a paper consent that hopefully gets put into back to school packets that families can fill out. If there is no physical signed consent on file, we do a telephone consent with two people that listen to the conversation and do a verbal consent over the phone. We are so close to implementation of our electronic consent. Is actually sitting in our legal department ready to go out. And then so what will happen is that basically the families will receive a text message or an email. They'll click the link, fill out the consent, and then it'll get submitted to their chart.
That's awesome. We're right there with you. So although we do these back to school kind of welcome packets at the beginning of the school year, just like they get all their schedules and everything else, the consent, a telehealth consent form, and also like just telehealth information sheet goes out. I'm just kind of asking for their insurance. What kind of insurance do they have? Is it private? Is it Medicaid? All the basic information we capture. We also capture that telehealth consent at the beginning of the school year. And then we have a team that kind of reviews those and makes sure that they're complete. If they don't have one, there's sometimes some at the front desk. So if we know that like a parent needs to come by or have them fill it out at some point in the day, the parent can do that as well. And then for our specialty appointments that might not have like a really comprehensive school-based program like that, what we do is that we will do the same thing. We'll send out a text and have the parent kind of fill it out remotely, or they'll do a verbal consent on the call with that parent and any additional support staff. But then in some of our specialty care appointments, like they'll have their initial visit in person. So they'll ask for telehealth consent there at that in-person visit and say your follow-up care will be via telehealth. Do you consent to that? And that way that provider already has it on their record as well, just as a backup. So both sites will have it. The school keeps their own record, and then that provider at the distance site keeps it as well.
So I think that's so great. Again, just making sure everyone's on the same page, all your bases are covered. Super important. I'd love to know if either one of you or both of you could share maybe something that you see in like year 2 or 3 that you might recommend, like as programs get off the ground but aren't in year 1 yet. Maybe some of the like QI you might recommend or updates or changes, maybe a policy and procedure that you've seen be really effective as kind of folks start to really solidify their programs.
So one thing that we've done many PDSA cycles on how to increase our telehealth numbers. Sometimes we're very specific to one building, sometimes it's school district, and sometimes it's department wide. But we found that incentives work. So doing anything to incentivize the telepresenter to actually refer and telepresent, it does work. And then we also have kind of perfected our training over the time. We just kind of thought that we would just present it on a screen and people would know what to do. And by year 2 and 3, we kind of realized quickly that that's just not how people learn. And so they need that hands-on simulation-based education on how to refer and how to run that telehealth equipment. So that has been very crucial to the success of the telehealth.
Same for us, the education and the constant training. I mean, we have an account manager dedicated to just our school-based health systems. Like they work a day in, day out. So like now today and like this month, she's like, okay, winding down, like all of our schools are closing, they're wrapping up, school nurses are packing up. Here's where we're at. They have a, 1 week post, students. So I'm going to go do some of my site visits and meet with them to strategize and see what they need over the summer so that when they come back in August, that they're ready to go. And then she's scheduling any as needed trainings for the summer, refresher training, new staff training, that onboarding and that transition training. But also for our parents, like we do end of year, like we are very immersed in our families at the school system. So if the school is telling us that they're having like a health fair or an end of year or graduations, like we set up a little telehealth display as well, just like them to be part of that community. If they need any support from us, like we are there with them so that the parents and the families see us and know that we're not just a vendor coming to them, like we are part of their community and are part of their initiatives. So anything that they need, they know how to ask us. So really for us, our recruitment method is really more the families and the parents. Like, hey, you were able to join in on this consultation. You can be a part of it. Just because your kid is being seen at school doesn't mean that you're being left out and you're not included in these visits. So we send them the text or the link and we tell them, hey, you are included as part of these consultations. What else do you need?
I love that example. I feel like both of you really touched on this like whole community, whole school kind of thing of care and the importance of bringing telehealth into that and school-based systems as well. Salim, I'm also reminded of your example as far as like motivation and buy-in goes of the cheerleading and like physically going in there and making sure that you're connecting with providers and making sure that you're really having that like FaceTime and acknowledgement of like we see the work that you do and the impact it's having on our students and our communities and like that's really important I think for everybody. And I just love that visual of going in with your pom-poms.
Yeah, like some schools have even said, like, hey, as school nurses, we love this, we support it, our families love this, and we need it, like at a local school or even at the, district level. But then their administrative staff might not even know that they're offering this telehealth service. So for them to like, hey, can you come in maybe once a year and give us a certificate? Like, can we earn some kind of award? Like, what can we do so you can show us that we can show them the value of this and maybe more funding can come around for it, or if they need additional staff, or if they need maintenance on some of their equipment, if it's, $2,000 when they're asking for it, like they're already seeing that return on investment. So we're like, absolutely, what can we do? Like, what kind of awards do we need to give out? Do we need to host an annual, like, what do you need? And that's really what they're asking. Like, our schools are asking for that specifically.
Amazing. Thank you so much. I love that example. Um, Awesome. I think I would ask both of you just kind of your final thoughts, maybe final advice for folks on the call here, related to telehealth and maybe just any parting words you have for our participants today.
I'll start.
Um,
I think oh, go ahead.
Go ahead. No, you go ahead.
I was gonna say, one, start small. Like, it's okay to start small. One school, one community, or one school, one specialty. If behavioral health is your bread and butter and you see that's what your kids need the most of, start there. Work with your local CSP, work with a provider, and then build on that momentum. Like, don't come in guns blazing thinking you're gonna do everything at once, because not only is that gonna overwhelm your students, it's gonna overwhelm your staff, it's gonna hit a lot of funding issues. So start small. I also say take your time to research platforms and software. It is very expensive to find hardware. It is very expensive. Sometimes hardware comes with subscription. I think there was a question in the chat about subscription fees. Like, yes, some of these platforms are very expensive. And if you don't have that backing of big healthcare systems to support you, it could be very pricey. But you can do it on a shoestring budget and not take away the quality. So that's where I say lean into your telehealth resource centers who are completely neutral and vendor neutral, and they will tell you who's out there, who are the players in the game, who is doing similar work, and what the costs are, and they can connect you to those other low cost solutions. Again, there's not one that's better than the other, but we know that funding is an issue for certain organizations. So be mindful of that and find something that works for you.
I agree as starting small. I think that that's a really good piece of advice. You don't have to, come in with multiple devices in multiple school districts to make an impact. Try just one school, one community, and see how it goes. Also, just remember that I don't, if you've been in school-based health, almost every year is a rebuilding. You learn from the year before and you improve. And so, just because it didn't go exactly how it was planned in the first year doesn't mean you can't make significant improvements and make it better the next year. So don't give up after the first year. I would say it probably takes a good 2 to 3 years in a school district to really see the impact and the buy-in of the community. So make sure you have enough time to work it out that way.
I agree. I'll also say I've seen school systems that have been up and running for like 8 years, and then one day they call us and they're like, sorry, we're not doing this anymore. And we're like, oh no. But we understand that administration changes, priorities change, leadership changes. So sometimes they'll go ghost and quiet for a year and then they're off, and then changes come back and we circle back and we're like, okay, like, what do you need? Or is this your leadership now understand what telehealth is? And are you open to us having a conversation with them? So to Teresa's point is like, don't give up. It is not easy to start off in. It's obviously added value and additional work, but your families will truly appreciate it. And once your school system and administration start seeing that return on investment and your providers in the community see it, that's when you start getting those champions to help you support it and to, fight for you and advocate for you.
Thank you both so much. I feel once again I've got so much to think about, and I hope that everyone out there does as well. I'm gonna pivot us just to our closing. I want to be mindful of time. I know folks have to go back to work, have to go back to clinic. So one last thank you so much to Salima and Teresa. I'm going to quickly show a poll, give us some feedback. We would love to know what you learned. This helps us in future offerings and also report back to our funders to know what was helpful. As you complete that quick poll, I would love to remind everybody to come see us in DC. We would love to be able to connect with you in person, have you connect with one another, learn from folks in the field who are doing amazing work. We've got some telehealth offerings, which is really exciting. We also have everything else school-based healthcare. You can scan the code there to register. And it's crazy. I don't know what happened to the month of May, but yeah, it's almost June already, and it'll be here before you know it. So we hope to see you there. And just a reminder to stay connected. You can find more webinars like this one by subscribing to our digest, by visiting us online through our social media platforms, or visiting our website at www.sbhforall.org. And I want to say a huge thank you once again to our presenters and for all of you for spending your afternoon with us. We will be sharing the slides and the recording and any additional resources after the webinar, so just stay tuned. Salima put her email there in the chat if you'd like to follow up with her. And if there are any lingering questions, I will stay on for a minute or two, but thank you all so much and really appreciate you coming and spending your time with us.
Thank you so much for having us.